My, oh my. Hello, everyone. So good to be with you for SADS Live 169th episode. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic, and I have had the privilege of serving as president of the board of the SADS Foundation, your organization, the Sudden Arrhythmia Death Syndrome Foundation, for quite some time. And we have been away from each other. I don't know where you went. I've been here every Friday. No, as you know, I haven't. And now it's a Tuesday. So same thing, different day, different time, trying to make it a time that I can be here with you and take on your incredible questions, and I'll attempt to deliver equally matched answers. I love this, and I've missed you. And I'm thinking of you, Julie, your grandson. Think of him each time I put on the hat that you gave me. And in fact, there's Julie. So, Julie, I didn't even see your name come up when I grabbed that. So, what a time we've had. What a year we've had. And this is, speaking of year, we are wrapping up the last week here in October of Sudden Cardiac Arrest Awareness Month. Hopefully you've been involved in that, been seeing some of our activities, contributing to that. We're coming towards the end of the year, thinking of your year-end donations. Maybe have SADS Foundation there. We made it easy. Top right corner, donate now. We would love to have your year-end gift. We have been involved in our new chapter of SADS Foundation with our new CEO, Walker Fromm. What an incredible transition that's been. It's exceeded anything that I could have hoped for. So we at the board are incredibly impressed with Walker, proud of the transition team, grateful for Alice Laura and what she did for all of these years, decades, to set us up for success. Since we were last together, we've launched a new SADS chapter in the world, in the country of Brazil. So welcome to the SADS Foundation family, SADS Brazil, and that is led by one of my trainees, Dr. Raquel Neves. So shout out to her, shout out to SADS Brazil. And now, before I take some questions, and they're coming in, and I love them as we're streaming on 4 different platforms, 2 Instagrams, 2 Facebooks. I love it. Let's keep it going. But before we do that, I have to bring on an incredible member of the SADS team, and it's her last SADS Live with us. So Aaron, bring on Marcia. Marcia Baker, as you know, has been the director of our education program for many years now. She has been in the nonprofit sector for cardiology and healthcare in general, but cardiology for 40 years. She started when she was 9.
That's right.
And now she has decided it is time to head into a new chapter of life called sailing into retirement. So, Marcia, I just wanted to thank you and grateful for all you've done for the SADS Foundation. You really put our education pillar in a whole new next level of excellence, both with the healthcare professionals and the patient community. So, Marcia, thank you. Thank you. What's the first thing you're going to do when you retire?
Well, thank you, Mike. My first thing is going to be a vacation trip to Kauai at the end of the month. And so I'm looking forward to that. And it's been my pleasure working these last 7 years with the SADS Foundation and working with the medical community and all the families affected with inherited arrhythmias. So it's been a pure joy to work with everyone.
Well, it's been a joy to work with you, Marcia. You are just the best, and grateful for you. And in the words of the destination for your first retirement stop, aloha and mahalo.
Wonderful.
All the best. So Aaron's putting me on assignment now for the questions. So I'll go to the top. As you all know, the rules of engagement. I don't cherry pick. I take them in order. I don't pre-screen them. So I'll do my best. You can do your best to make your question as tight as possible, pithy, as they say. so that I can glance over at it. So Julie, I did that one. Sudden Cardiac Arrest Awareness Month. Yes, it is, and do that. Cheyenne gets question number 1. Good afternoon. My 2-year-old was just in the hospital because she was sick and experienced oxygen that went into her 70s. Her heart rate went high and she lost consciousness. It happened twice. Neuro said not her brain, but her heart. Could this be her CPVT? She's 2 years old and can't do beta blockers due to consistent low blood sugars. Really good question, Cheyenne. Now, I'm assuming, and again, the other rule of engagement, since it's been a while, I try my best not to give direct advice about your specific child, you, if it's about you, your sibling, your loved one, but to take the question and reflect on it, the approaches and the issues surrounding that question. Because obviously it would take like the 90-minute evaluation that I will do for the next new patient to unpack everything. So again, reminder, this is not direct patient specific, but hopefully the answers will help guide you. So if this is CPVT, I'm assuming that there's been a genetic confirmation of it being due to a mutation in the RYR2 gene. It's said that's not tolerating the beta blockers because of low blood sugar. That issue, as it turns out, is present, but it's not super common. We published a paper decades ago now about hypoglycemia, low blood sugar, in long QT patients, particularly LQT1 and LQT2. And it turns out that there is a subclinical pancreas insulin secretion control phenotype in those patients because of their defective potassium channel mutation that also resides in the beta islet cells of the pancreas. But it's really mild, almost never noticeable. Very rarely will rear its head with low blood sugar in the small bodies, but we almost always can navigate around that with just awareness, with just timing of caloric intake around the dosing, and to make sure that they don't go to bed in a fasted state. So maybe not, one can readdress whether there's room for beta blocker therapy. If there's not room for beta blocker therapy, we do have treatment alternatives for CPVT. They include flecainide, they include left cardiac sympathetic denervation. As to the symptom, desaturations to the 70s is almost never CPVT. And the heart rate doesn't go high in CPVT, it goes high and abnormal. So it's not just sinus tachycardia. So maybe there always is the ongoing detective work to make sure we know whether we're blaming the correct organ for the symptom. And thanks for the welcome back, everybody. And Julie, if I have safely taken a hit-list medication before I was diagnosed, do I still need to be cautious about it? And Julie's referring, of course, to that incredible website, www.credible.meds.org, for our long QT patients. And there's a similar one, www.brugadadrugs.org, for our Brugada patients. Now, importantly, those two websites do not matter at all for our CPVT patients. Does not apply. Our ACM patients does not apply. So when we speak about these, we have to make sure, is he talking about my family's condition? This is specifically about Julie's, which is long QT. And in general, I try people to avoid those medications as long as there's a suitable alternative and as long as it's not an emergency. And in most times we can find a suitable alternative. But I have many long QT patients who are on medicines that do reside on that so-called hit list. So it's not a mandatory, it really is a patient specific, tailored to the situation. And mostly I would say I put the priority on prescription medications that reside on that list. The over-the-counter ones, not so much. They're on that list. I'm not in complete agreement about their listing. I see why we've done it out of an abundance of precaution. But to date, I have never, as in never, had a long QT patient with diagnosed, known, treated long QT have an event from their over-the-counter cough medicine, their over-the-counter Benadryl, and so forth. So I know they're there, but I think they are super weak. But again, always review things with your physician, because it may depend on what are your other medications, what are your other health issues. But great one. Thank you for that, Nancy. Kim, her daughter's 22 and has been recently diagnosed with Brugada, but never a symptom. She's asking, would she do anything if she wants to have children? In general, my patients with clinically diagnosed with or without genetic confirmation Brugada syndrome are welcome to create as many children as they desire. I'm not worried about pregnancy for a woman with clinically diagnosed Brugada. I'm not worried about labor and delivery. Basically, I'm not worried at all. So would we monitor baby? Depends on, is her version of Brugada genetically known? Well, then we would have the ability to do family cascade genetic testing to determine whether baby did or did not inherit the Brugada susceptibility variant. Alona is asking whether long QT syndrome can cause PVCs. I've never had it until after I was diagnosed, and now I have 600 daily. And can this be harmful for me? Great question, Alana. Never had that one. So that's a new one for all of SADS Live for as many years as we've done this now, which is 5 years and counting, I believe. So PVCs are premature ventricular contractions. They come from the bottom chamber, the ventricle, and they're early beats, extra beats, skip beats. They go by different names. And in general, long QT syndrome patients do not have background PVCs unless any more than the general population. The PVCs that they have are PVCs that then become their symptom, and that's when the long QT goes into the danger rhythm of long QT syndrome called torsade de pointes, which is a lot of PVCs of polymorphic pattern stringing themselves together for 1001, 1002, 1030, and so forth. So isolated single PVCs in this background frequency of 600 is not a lot. So it depends on whether they are new or different. It depends on how they cluster, or do they cluster. It depends if they're all single. But as a general rule, long QT patients can have the same rate of background single PVCs, which for many people is on the order of 600 to 1,000 a day, 1% burden, and they do not matter as a general rule. Now, would I want to see those PVCs? Would I want to see what the Holter looks like? I would want to do all my detective work to make sure that there's not something else going on besides the normal background rate of skip beats that happens to be in a person who also has congenital long QT, but they're not from your long QT syndrome. And Allison has a 15-year-old female that just experienced a cardiac arrest. This is SCA Awareness Month, on a softball field 2 months ago on August 30th. She was seen at a place, received an SICD. Initially, she had prolonged QT and now normal. What are the next steps? So a lot to unpack there. First, I would say as a general rule, when a person has sudden cardiac arrest, first, I'm grateful that there was a safety plan in place. It sounds like the safety plan or the emergency plan was activated beautifully, that there's been a nice recovery, as I'm assuming here. So grateful for the American Heart Association chain of survival, that we act quickly. We recognize a collapse as not being normal. We activate 911. They run to her. And in our program, for our patients with known diagnoses, I call it the 10-second rule, like in boxing, a 10-second knockout. If they haven't regained consciousness within 10 seconds, you assume sudden cardiac arrest is in motion. You activate the chain of survival. 911, chest compressions, grab the AED, put it on, hit the shock button if instructed to do so. So thankfully for Allison, it sounds like that was done well. Then what we need to do is the detective work. Why? Why did that happen? And it's not unusual for a sudden cardiac arrest survivor to show QT prolongation in the aftermath. That almost often causes a preliminary diagnosis of long QT syndrome, which may or may not be true. And when that QT normalizes, that means timeout. Do we need the ICD? Unless we've identified a reversible cause, an ICD is essentially the law of the land as a secondary reaction. It's called secondary prevention. But we need to know the why. What's the name of the disease for that cardiac arrest? Because it is possible, depending on some of the names, that we may not need that ICD indefinitely. And in some situations, we actually reverse course and remove the ICD if, say, for example, we subsequently proved that the right name of the disease was CPVT, where our CPVT families know that we often try really hard not to put in an ICD if we don't have to. So a lot of detective work is really the next steps. Now that things have settled and the person's back to normal, doing a full cardiac evaluation, which must include a stress test and maybe include genetic testing. So the detective work begins. And that's one of the observations I would have out there is often after somebody gets an ICD for whatever reason, it's as if we, the medical community, turn off our brain and we stop asking the why. And we just say, it looks like it was unexplained. And for years, that unexplained cardiac arrest survivor may never have gotten a treadmill stress test because they didn't do it during that patient's first hospitalization. So really the detective work is just beginning, and I wish you the best with that. And Rose is asking, not a trick question, but a good question. Do I know of research into LQT15? Now, I might be embarrassed because my program might have discovered LQT15, and now I can't tell you the name of the gene responsible for it. And part of that is because for the last 10 years, people like Arthur Wilda and I have strongly encouraged that we stop using the number for the minor genes. So we stop using LQT4, LQT11, LQT9, and we instead refer to it as the genetic name. So if LQT8, which many of us know is the calcium channel, then we would call that CACNA1C mediated long QT syndrome. Some of those in the teenage range, like the 15s, some of those are the calmodulinopathies. And so we would call it CALM1 long QT syndrome, CALM2 long QT syndrome. If it's referring to triad and knockout syndrome, we would call it TKOS, mediated long QT, because that way everyone knows what we're talking about. And some of these minor genes have gotten demoted to where now that number is a placeholder. So a long-winded way of saying, Rose, I'd have to quick Google which gene is the one that we said is LQT15 and then work back. And I'll look down to see if you add the name of the gene and see if we can come back to that, or we'll do that the next time. Suze is saying, hello. Been diagnosed with ARVC in 2008 from PKP2, the number one gene for ARVC, which builds the protein type 2 plakophilin. She has an ICD and am maintaining. I'd like to begin adding some at home, lightweight training to my yoga and golf. Go for it. I think we have not handled our exercise recommendations for ARVC very well. Is there data? And the data is largely from Hopkins, and it's an incredible ARVC center there. And I think the data is rock solid that high intensity endurance training activities are disease activators potentially, disease agitators, and disease accelerators for PKP2. And I think we know that now. Now, what we don't know is for somebody who owns the mutation but does not show the disease, so-called genotype positive or phenotype negative, what's the likelihood that that level of training will bring out the disease for the first time? Phenotypic conversion. Because we don't know that, and we know that half of all mutation positive patients will never show the disease, and some of those were athletes by the time they eventually got discovered. I don't like, and I have not liked for 20 years, the couch potato designation for our PKP2 families, meaning you don't get to do anything. Don't get up, don't walk more than walk to the bus, don't do anything. And I think we've hurt families. So we try to encourage some level of activity, a lot of level of activity. I have no concern about weightlifting, for example. Do I discourage marathon training in my PKP2 patients? I do. Do I discourage Ironman, Ironwoman training? I do. Do I let my PKP2 athletes who are tennis players play tennis? I do. So it is very much a patient and a family and a shared decision-making process. But the default of you cannot do anything ever, that default ended in my program 25 years ago. And finally, other programs are starting to embrace that approach. Allison is sharing with me that the genetics is negative, and I got to look back up. Oh, that's for the sudden cardiac arrest survivor. Asking of what an appointment looks like, and do we have specific therapists that you work with for young athletes? So a couple things there. So the evaluation, as many of you know who have given me the privilege to take care of you, is quite involved. For our program, it's a 2 to 3 day evaluation. We try to do it in 2 days. It includes a lot of the standard cardiac tests, some of them repeated, and then I get a feel of what I think is the name of the game. The therapist part, very important. We've had some programs about the role of therapy, mental health, and the journey of anybody diagnosed with a genetic heart condition, and those especially who are the SCA survivors. Because our patients come to us from all over the country and the world, we have not systematically incorporated a therapist as part of that, but for them to find somebody locally who will work with them and partner with them, because it's just, you can't really do justice to a one-time visit to say, yeah, you're struggling. Yeah, there's elements of cardiac arrest survivor PTSD, and let's work on this. So we really need to find the local counselor, local therapist, if a person needs that. Now, I have many sudden cardiac arrest survivors who have not needed, don't need that at all. There are others who are struggling, and whichever they find themselves in, we need to meet their needs. Dana's asking whether I have had any opportunity to advocate for long QT to enter the military in the US. 2 boys want to join. First, I thank your sons for wanting to serve in the military. I'm grateful for all of our military men and women. Yes, we have had success. It's complex and it's complicated, and I think there's things underway that are going to help. Namely, there is a guideline document or a consensus expert statement about what we're calling the tactical athletes, and those include our men and women in the military, our firefighters, our law enforcement officers, and so forth, to give guidance as to what may be reasonable stay in the game scenarios, or allowed to enter the game, meaning be allowed into a particular branch of service. It's going to be slow progress, but I have successes, many of them now, where they have been permitted to serve in the military. Katie was saying, I wake up gasping for air and not able to breathe. I've seen some of this associated with long QT. What can I do? I like the question, Katie, because there's a lot, I would say, of myths out there with these. Never in my career have I seen this gasping for air and not being able to breathe to be part of long QT. It doesn't make sense why it would be. So I would not be ready to put the blame on a person's genetic heart condition for a symptom that doesn't fit. Now, I'm always ready to realize that never say never, and always is never true. So one has to be careful with that. So I'd be wanting to hear the story, try to understand what they're describing, but I would be personally in a scenario where I don't think it's part of the genetic heart condition, working with that person's primary care provider to first explore that and then to see if additional things need to be done. Incredible question. We're going to have to continue this. Kim, well, hello, Kim. I recognize that name. Your daughter's genetic test was negative. It shows the type 1 pattern. So that was back to the person where her daughter was diagnosed with Brugada and asking about children and procreation, for which I gave thumbs up about the idea for all of my patients, almost all of my females who want to become a mom, and and in the proper order, can I say that? That I'm not afraid. And certainly I'm not afraid of a woman with a type 1 Brugada ECG pattern becoming a mother. Not worried about labor and delivery. I'm just not worried. Now, in this case, we have SCN5A negative Brugada. And is that unusual? No, that's the norm. Remember, in Brugada syndrome, only about 20% of all Brugada is SCN5A mediated, maybe as high as 40% if there's the concomitant feature of a prolonged PR interval, also known as first-degree AV block. But if all they have is the Brugada pattern and the PR interval is normal, the yield of the genetic test is actually only 10%. So we should never be surprised for somebody who gets diagnosed with Brugada syndrome may really have the Brugada ECG of concern and their genetic test is negative. It usually is negative. So that just means that when they do procreate, we will be evaluating their child based upon electrical features only, because we will not have the benefit of genetic guidance. Katrina is asking me if Zepbound or any of the GLP-1s are safe for long QT2. Such a great question. And over the last 2 years, I now have had a lot of patients with long QT syndrome who've had their concomitant unhealthy weight issues, shall we say, addressed with the GLP-1 agonist. And I'm not afraid of any of them. I have not seen any signal of a QT concern, of an arrhythmia concern. What I have seen for many of them is unbelievable success in their weight loss. So I'm not afraid of those. Now, do I believe that we need to work on the old-fashioned way of losing weight, which I'm working on and I've done, so I'm holding myself accountable, and that is caloric management and exercise. Burn more calories than we consume. Weight loss is a law of the land then. Now, with my long QT patients, do I make it harder for some of them to lose weight because of their beta blocker? Some yes, some no. I'm convinced that beta blocker certainly is not a helper for weight loss, but I think sometimes it's getting a disproportionate amount of the blame when they haven't really done the caloric management side of the equation. And coming around the finish line for this return of SADS Live, which has been a blast. I'll come back and pick up roses. I did skip only because I saw it and it was with reference to long QT number 15. And she shares with me that that's the Calm 2, which we published now several years ago. So I'm ashamed that the CALM1 and CALM2, which those two genes were discovered by Leah Crotty and Peter Schwartz in Italy. And then we added the discovery of CALM3 long QT and then published one of the early series about CALM1, CALM2, CALM3. The update I can give you, Rose, and point you to is keep eyes on. So Leah Crotty, Peter Schwartz, and I have this international calmodulinopathy registry, and we publish an update of it every so often when there's enough lessons to be learned and to share. And so I would go to that search. You can do a Google search for my name and calmodulinopathy, Leah Crotty's, Crotti, and her name, and that will bring you to some of the latest work that's being done in terms of at least better understanding how this disease behaves. I would say the overall punchline of a new observation, and this is true of all new rare syndromes, when a new genetic heart rhythm syndrome associated with sudden cardiac arrest or sudden cardiac death first gets published, almost always those first publications give a sense that this is a really bad one. This is a really bad one. And then over time, as we learn more and more about that entity, about the spectrum of CALM2 LQTS or LQT15, we discover that maybe not as bad as originally advertised. A beautiful paper was written about this phenomenon by Arthur Wilda, and it's true of basically every genetic heart disease ever published. The initial forecast is almost always the most severe, and over time it gets better as we understand more of the breadth of the entity. And now back to taking it in order. And we'll do EWAS. I'm a woman, her QTC is 480. Her father is 64 and accidentally found his ECG and saw that his QTC was 470. And you've tested negative for the 17 known genes. Mutations, there's hundreds of mutations, now thousands. While my father hasn't been tested yet, could this be an individual trait or is it consistent with long QT syndrome? Really good question, Iwa. And I think whenever I have patients with a QT interval that is approaching the upper limit of normal or the boundaries of what we would call the 99th percentile, which in healthy men, it's 470. In healthy women, it's crossing 480. So just because I cross that threshold, does that equal long QT? No, it doesn't. Does it increase the chances of having stumbled into long QT? Yes, it does. So if one does the math and says, what's the likelihood if it was you alone and you're 480 that you have long QT syndrome? Not very high. If there's no symptoms, no family story, 480 is a 99th percentile value in health. So let's say 1 in 100. How many people have long QT syndrome? 1 in 2,000. How many of those are under 480 and still have long QT syndrome? Well, that's 1 in 4,000. So we're comparing 1 in 4,000 to a 1 in 100 chance. So that number by itself means a 40-to-1 odds of I'm just an outlier. I don't have long QT. But now I add a second relative, and that second relative is also in that 40-to-1 odds. Now, is my collective risk still 40-to-1? No, it's higher, but it's still more likely than not, if I have healthy people, no story, and just 2 isolated QT numbers like that, that I probably just have 2 outliers, 2 healthy outliers. Now, I would do my due diligence. Maybe both of those individuals have a QT prolonging exogenous factor. So that's why they're out there past the 99th percent. So there's a lot of reasons and would require the detective work. Well, I will finish with Dominique's, and hers is really good. Any info suggestions on allergy shots and long QT syndrome? Great question. There's an article either soon to come out or has already come out about that. We wrote a viewpoint paper. My heart rhythm, my genetic heart rhythm partner on our Mayo Clinic Florida campus, Andrew Sang, and I wrote this viewpoint letter to show what's the evidence or lack of evidence that allergy shots are potentially dangerous in long QT, almost never, that beta blockers are contraindicated for allergy shots, almost never. So there's been a lot of mythology surrounding allergy shots and beta blockers and long QT and the epinephrine rescue pen and so forth. So I would suggest try to find that article that will give you the best information. But bottom line is, in my patients with long QT or CPVT who are on beta blockers, or my ARVC patients who are on beta blockers, if they have concomitant allergies for which allergy shots may be recommended and pursued, I don't worry about it. I haven't had a reason yet to give me pause. Well, that's a wrap. Wow. I remember why I've missed this so much now. That was incredibly stimulating. I hope it was helpful for you as we did rapid fire. We will be back doing this. We are going to try with this new time, Tuesdays, tell your friends, same time, 11:20 to noon Central Time. So adjust your calendar in Australia now, or wherever you may be, to do this with you. And we will try to do once a month of questions and answers with yours whenever possible. And the other one, to have a featured segment of an interview or some advance or a progress point that's being made related to your heart condition. So until our next time together, be well. I hope you like this time frame. I do. I can fit it into my day much better now. I blocked it on my calendar starting in 2026. And so I will get to be with you again, hopefully in a reliable, consistent way. I love it. I hope you do. And I love what we're doing together with your SADS Foundation. 2025 is coming to a close. Think of us. If you're able to donate, we would love that. And we would be grateful for your gift of any kind in any measure. Until our next time together, take care, everyone.